Many things were already said by the previous speakers, my conflict of interest. So why is it important to avoid fluid accumulation? I think that you know, because it was said before, fluid overload can lead, or accumulation overload. I don't want to play with the words. I know the difference, but okay, I would say accumulation or overload. Sure that overload can lead to multiple organ dysfunction. It also can lead to increased mortality. This is a paper you already saw before by Jean Louis Teboul and others, showing that in septic patients, a positive cumulative fluid balance was an independent factor associated with mortality. This is very important to know. And this was replicated many times. I don't want to see all the studies. But this is an interesting one, published some weeks ago in an order of intensive care. They separated patients in function of the day they measure fluid balance. And what they found that they compared with a propensity score matching patients with negative fluid balance and patients with positive fluid balance. At day 1, they had a similar survival. But at day 2 and at day 3, patients with a positive fluid balance had a lower survival. So it is very important also at the beginning not to avoid to give fluid to patients in shock. It could be not very good. But after, we have to think, after the salvage period. Also in ARDS, it is interesting also to think about ARDS patients. This is a study we did with Mathieu Josiac, Xavier Monet and others in my unit some years ago, and we confirmed that the mean fluid balance during the stay of the patient was an independent factor associated with mortality. So there are a lot of arguments to think that fluid accumulation can be detrimental. But now, how to avoid, how to prevent, if you want. First, by using norepinephrine early in patients with shock. And this is easy to detect by looking at the diastolic arterial pressure. A low diastolic arterial pressure in general is a good marker of a low vascular tone, in general, in the majority of cases. And this can help you to identify patients who need vasopressors and norepinephrine. And how can early norepinephrine avoid fluid accumulation? What are the mechanisms? In fact, with Olfaim Zawi and others, we performed a study in septic shock patients some years ago, 105 patients, where we gave norepinephrine very early, at the time patients arrived in our ICU. The diastolic arterial pressure was very low, 49 meters of mercury, 49 on average. No, 49 was for the mean arterial pressure. It was less than 40 meters of mercury. MAP, 54 for the mean, sorry. MAP went up, stroke volume index, cardiac index went up, but also the global diastolic volume index went up. It is a marker of preload, and pulse pressure variation, which is a marker of preload responsiveness, went down. So we observe an increase in cardiac preload and cardiac output and decreased preload dependency with early norepinephrine. And we did another study with Xavier Monet, and we found more or less the same results with other methods. And finally, the messages of these two studies were that norepinephrine can increase cardiac preload, cardiac output in preload-dependent patients, reduce the degree of preload dependency. This is exactly as fluid infusion does. So it is like fluid administration when you give early. So how does norepinephrine impact the venous circulation? Probably, as suggested also by Daniel De Backer before, by blood redistribution from the unstressed to stressed volume. And to try to confirm this hypothesis, with Romain Persichini, Xavier Monet and others in my units years ago, we tried to estimate the mean systemic filling pressure, which is a good marker of this blood redistribution from unstressed to stressed volume. And we found that in all patients, cardiac index increased, this was confirmation, and the mean systemic pressure increased with norepinephrine compared to before. So it increases. And in spite of the increase in venous resistance, because also norepinephrine is able to increase venous resistance, but in spite of this, there was an increase in venous return, an increase in cardiac output with norepinephrine through an increase in the mean systemic pressure related to blood redistribution from unstressed to stressed volumes. This is a way to avoid to give too much fluid at the beginning. And we tried to confirm this in another study with Imanada, Xavier Monet, and others 2 years ago, and we combined norepinephrine and fluid, and we looked at the change in the mean systemic pressure. We did not perform fluid administration, but passive leg raising as a stimulation of fluid challenge. And finally, we found that there was an increase in the mean systemic pressure when you combine. So it is good to combine. You can have a very good effect on venous return. And does really now, early norepinephrine really reduce fluid administration? Are there some studies about this? Yes, there are many studies. One of them comes from Gustavo Spinatascon and others, Glenn and others. And in this study, it was an interesting study. It was not a randomized controlled trial, but a propensity score matching study to populations of patients, similar populations, and patients who received norepinephrine very early means in the first hour after arriving, if you want. And they received less fluids due to a mechanism I talk about, compared to norepinephrine, delayed norepinephrine administration. Very interesting. And also in this study, the mortality rate was different. And very impressive when you look at this slide. It was not a randomized controlled trial. But, and I don't say there's a real link between fluid accumulation and mortality, but this could be suggested. And now, it's not the only thing to do. Should we use a deliberate restrictive strategy, systematic restrictive strategy after the salvage phase? Could be a good solution, maybe, to limit fluid accumulation. Normally, yes. Is it true? This is an interesting trial, the classic trial by the group of Anders Perner and others, and they try to address this question. In patients with septic shock, should we use a restrictive strategy after the salvage phase, of course? They included patients after the initial resuscitation, but look at the numbers. They gave a lot of fluids before, in the first 24 hours. 41 ml per kilogram in the restricted fluid group, and in the standard group, 38 ml per kilogram. Not negligible. And after they randomized, restrict or not fluid administration. No difference. No difference. And another study published this year in the New England found more or less the same results. Again, they gave fluid first, 2 liters on average, pre-randomization on the left, and they randomized patients with sepsis and persistent hypotension. After 24 hours, patients received more than 3 liters in the liberal group, and in the restrictive group, 1 liter and 700, on average, of course. And if you combine pre-randomized fluid administration, pre-randomization fluid administration, and what they received after randomization, look, in the first 24, 28 hours, they received more than 5 liters in the liberal group and more than almost 4 liters in the restrictive group. It's not really restrictive group. Nevertheless, there was no difference in mortality and the other secondary outcomes. But the common feature of these two RCTs is that the patients were randomized without any prior assessment of fluid requirement or fluid responsiveness. So some patients who needed more fluids were probably randomized to the conservative strategy, restrictive strategy, with an inherent increased mortality, and some others who needed less fluids were probably randomized to the liberal strategy arm with inherent increased mortality. And at the end of the day, this can result in neutral results. But let's remember this very old paper, 2006, in ARDS patients, looking at the same question, restrictive versus liberal strategy. No difference in mortality, like in these septic shock studies. But there was another analysis of this trial, and they look at their patients afterwards, and they subdivided the population in two groups according to subphenotype. One and subphenotype 2. Subphenotype 2 was characterized by more inflammation, more markers, higher markers for inflammation, and more shock, and more use of vasopressors compared to the other one. And what they found? They found that there was a lower mortality with conservative fluid strategy in subphenotype 1, but a lower mortality with liberal fluid strategy in subphenotype 2, confirming that it depends on the patient. You cannot adopt the same attitude to everyone. And we need to identify. We cannot systematically apply the same strategy to all patients. And we need to personalize the strategy according to subphenotypes or according to other markers. So what could be the personalized fluid management strategy now? So it makes sense, but know that even if it makes sense, there is no evidence in the literature so far that personalized fluid strategy may result in improved survival. But it makes sense. So how to do? We have a balance, beneficial effects we can expect, and detrimental effects also. And it's crucial for me to assess the benefit-risk balance of fluid therapy before administering fluid. After the salvage phase, again, after the salvage phase. So how to do? Benefits can be assessed by indices of fluid responsiveness. You know that not all patients are fluid responsive. This is what we observed years ago. Only 50% of patients are fluid responsive in shock patients. And I don't want to go into details in terms of indices of fluid responsiveness. We have many indices now. And there was an interesting small study, but randomized study by Jean-Christophe Richard and others in France, a group of Claude Guérin, looking at the effects of using fluid dependence parameters, essentially passive leg raising in this study, compared to control with only MAP and CVP. And as you can observe, they gave less fluids in patients who were managed according to preload dependence parameters. It makes sense, but this was demonstrated for intravascular volume expansion, intention to treat or per protocol, and also for RBC transfusion. So this is confirmed in a randomized controlled trial. The risk can be also assessed by indices of lung tolerance. I use lung water, but some others can use other parameters. And why lung water? Because, as said before, we showed in this study with Mathieu Josiak and Xavier Monet that lung water, extracellular lung water, was an independent predictor of mortality in ARDS patients, so it makes sense to use it. And there is this nice study, old study, many people forgot this study, but this study showed that compared to patients managed with a Swan catheter and POP, the cumulative fluid balance was better maintained in the group of patients managed according to the value of extracellular water. Not only the fluid balance, but also the duration of mechanical ventilation and the duration of ICU days. PVPI also, it's interesting, it's a marker of the lung capillary leak, and also it is associated with outcome in ARDS patients as we demonstrated. So what can I propose very quickly now? In a patient with septic shock, we have the salvage phase, and you can give fluid, but you can also, according to some markers, you can individualize your fluid management even at the early phase. I don't want to go into details. And after some time, if shock persists, you have to use the fluid responsiveness parameters. And two possibilities: either pleural responsiveness is still present or not. If it is still present, you look at the presence of severe associated ARDS. If not, you can consider another fluid bolus. If yes, if there is an associated ARDS, you have to assess the benefit-risk balance of further fluid administration. You have to take into account many parameters: the severity of shock, the presence of acute kidney injury, lactate, the degree of pleural responsiveness, not only the presence, but the degree of pleural responsiveness, the severity of pulmonary edema, PF ratio, lung water, feeding pressures, ultrasounds, etc. And you make your decision. If the benefit is expected to be higher than the risk, you can continue fluid administration. If not, you can consider other therapies, and also, of course, if the patient is pleural responsive. Thank you very much for your attention. At any time, you will applaud me twice. At any time, you have to start norepinephrine if the vascular tone is assumed to be low, for example, by looking at the low diastolic arterial pressure. Thank you very much.
Thank you, Professor Jean Louis, for this great overview. We have 2 minutes for questions from the audience. Please, we have a mic there.
Paolo Trambaiola from Roma. I am the chief of an intensive care, cardiac care unit, not only few patients in shock. I have the same data in cardiological patients, irrespective of ejection fraction. And I believe that it's very important to management the fluid, because for the cardiologists exists only the diuretics, respective DFA. In your experience, because my data are very interesting, I copy your work, and it works very well also in this kind of patient.
Thank you for your comment and your question. Yes, my opinion is, I share your opinion about this kind of patients, of course. This kind of patient can suffer from sepsis or cardiac dysfunction by definition, by pulmonary infection, ARDS, etc. So we have to be very careful. We have to individualize, for me, at any time, even at the salvage phase, because if you have abdominal sepsis, for example, you can give more fluid than if you have pulmonary infection, of course, even at the early phase. So we have to adapt, and we have many markers now, even clinical markers, or the context, the clinical context, the history, the comorbidities, etc., count a lot.
Yeah. Okay, there is a question about if there are any results from the Andromeda Shock 2 trial. You know, Jean Louis is part of, but they're still ongoing, and we have 800 patients recruited from 1,500, which is the sample size. So I hope that we will have results by September, October next year. So there are many questions, but it's impossible. We are short of time. Thank you very much, Jean Louis, for your.
Thank you very much.